Welcome, everyone. My name is Xander Chowie with One Place Physical Therapy. I'm excited to introduce this brand new series called Best of Sarasota. In this series, we spotlight the top healthcare professionals and fitness professionals in our community. They are truly making a difference. Today's special guest is Dr. Jonathan Dattilo. He is a board-certified orthopedic surgeon. He specializes in joint replacement, and he works with Alexander Orthopaedics. Welcome to the show, and thanks for being here.
Thanks for having me.
Absolutely. So the first thing I want to get into is just your background. So what first inspired you to be a medical doctor, and then what further inspired you to specialize in joint replacement?
Kind of a domino effect, I think, a little bit. I think I always really liked science. So when I was in college, I tested out, do I want to do basic science and work in a lab and try to cure diseases and stuff like that. And it was interesting, but I missed the personal touch. I missed interacting with people. So that is what sort of drove me to pursue medicine in general. And then once you get to medical school, I mean, I had a couple of orthopedic injuries growing up, so that was maybe in the back of my mind, but I certainly didn't come in thinking I'm going to be an orthopedic surgeon. I think I came in with a pretty broad mind, and there are a couple other specialties I considered, but the one big decision for me is that I like doing procedures. I liked working with my hands. I like seeing tangible results when you can make people better. And so I think that's what I ended up gravitating to orthopedics because of that, because you get to really improve somebody's quality of life. And it's fun. I think it's very relatable. We've all been weekend warriors and had some kind of injury, that it tends to be very fun conversations. And then ultimately, knee and hip replacement, I just like the technology and how that becomes incorporated. And again, seeing that tangible result of that patient comes into your clinic really, really just struggling and missing the things that they want to be doing on a daily basis.
Yeah.
And then to be able to use that technology and see that tangible result and see that change in their life is just really rewarding.
Yeah, that's amazing. And it kind of brings up a good question as far as this approach has changed drastically over the years. Just go into your approach to joint replacement. Do you use just a certain technique that makes you stand out in the community among multiple different orthopedic surgeons in the area?
Yeah, I mean, you're absolutely right in how it's changed. I mean, even 10 years ago, people were staying in the hospital for 3, 4, 5 days, and our pain protocols were not anywhere near what they are today. We really just were throwing a bunch of narcotics at people and trying to control their pain that way. Whereas now it's much more complicated for a good reason, that it really has cut down on narcotics and using a lot of these novel research protocols and things that we incorporate. And one of the biggest things I think we also do a much better job now is preparing people for it. It's elective surgery, and just like anything else in life, the more you prepare for something, the better your outcome's going to be. And so whether that's having them meet with the therapist ahead of time, right? Get their house together ahead of time, make sure that they've got adequate social support, make sure that all the medical things are as optimized as we can possibly make it, just to give them the best possible experience that it can be. And I think for that reason, a lot of people are choosing to do it as an outpatient these days. I mean, that's been a total 180 shift from the hospital setting. And then, incorporating the newest technology, the newest techniques on the hip side, it's anterior hip replacements is just an absolute game changer. So much so that all my snowbirds, if they maybe have more social support up in Ohio or something, and they're going to do their joint up there, I just ask them, please, 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 you'll break my heart if you don't go find someone that does it through the anterior approach. That it's just a night and day difference. I was like, if you come back to me and you tell me you had a posterior approach, I would be so sad. So that has been an absolute godsend for people. And I think on the knee side as well, there's not an analogous like anterior approach where you don't cut any muscle. So that's what the anterior approach refers to on the hip. No muscle, we don't cut any muscle. Not so there's not quite as a drastic change on the knee, but it has gotten certainly less invasive and using some of that new technology and stuff too.
Yeah, and it's just faster recovery on our end as therapists. We love seeing anterior approaches because it's faster recovery. You have, of course, that anterior soreness from what you did in the procedure, but you're not actually cutting through muscle, which is exactly what you highlighted there.
Cool new thing on the horizon I'm starting to do, which is bikini incisions.
Okay.
I've done them. I have done them. I'm trained on them. There's pros and cons to it, but I think for the appropriate patient, it really, really makes for a nice scar. You can't even see the scar.
So as far as this approach goes, you mentioned the ideal candidate. Who is an ideal candidate for a replacement? Are you on the conservative side? I know you mentioned it's voluntary, it's the patient's decision ultimately, but who is the ideal candidate for replacement?
Yeah, I think first and foremost they have to want it. I think that anybody who tries to just tell someone, "Hey, you got arthritis, you got to have your hip replaced," like I think that's a really wrong like way to look at it. I think they end up making a decision, and that decision often in the story that I hear is that they start sacrificing quality of life, and that they start avoiding certain things that they want to do. They start going out to dinner with their family. I definitely don't want people to wait till they're debilitated and they can't get off the couch to do anything. So I think it's ultimately a balance. Are the non-operative things, the medicines, the injections, are those just not sufficient anymore for somebody to be happy with the quality of life? I think that's thing number one. And then I think thing number two would be everything else that we have going on, whether that's social support at home, whether that's any medical issues, that we can maybe make this as safe and as low of a potential risk, endeavor as we can. So I think that's that optimal candidate. I think a lot of people talk about weight limits and other things. And there's certainly, if there's something that we can make better, we do it. I don't have strict cutoffs. I definitely take care of some challenging patients, no doubt about that. But somebody out there's got to, and that's just a mutual conversation you have with the patient. Like, yeah, if there's something, whether it's diabetes, whether it's weight, there's something that's not perfect, but we make it as safe as we possibly can.
So as far as, if you do feel like you're an ideal candidate, to kind of walk us through the journey that it takes from initial consult with you, going through the procedure, and then the recovery. What does that look like in total?
Yeah. Let's assume, just for the sake of illustration, they've tried all the non-operative stuff and they're at the point where they want to move forward with surgery. And that involves an office visit, some basic x-rays. In 99% of people, that's all I generally need is an x-ray. MRIs and CT scans will sometimes add stuff, but it's really for minority of patients. Um, and then we start that optimization part. We have them see their primary care doc. We check some basic blood work. If they have other medical issues, particularly heart issues, we may get a cardiologist involved, all that to prepare them. And then as they're going through all that, on the home front, they make sure that they've got social support. I prefer that whoever that person is comes to see me with them at their preoperative visit, just as an extra set of eyes and ears in the room. They can take notes. There's kind of a lot of moving parts at times. Just an extra person to kind of, I call them their coach. And then if they're able to, or if they desire to, I love having them meet with a physical therapist ahead of time because, again, it's just one more piece of the puzzle that we can take away so that after surgery and they come in and they're maybe a little bit less mobile having just had surgery, they know exactly where they're going. They see a familiar face that they're working with. Some of the exercises may already be familiar to them depending on what they were able to do prior to surgery. And so then we plan all that. We do the surgery. I'd say more and more people are choosing to go home the same day these days. Probably about 70% of my patients who go home the same day, 30% staying overnight. If they stay overnight, it's generally just for a night. And it's usually for medical reasons. It's almost never pain control that people stay in the hospital overnight anymore. That's been a big change. But what we call our multimodal pain management protocols, utilizing a bunch of different non-narcotic medicines in addition to the narcotics, have really made the pain not the reason to stay in the hospital. It's because they're maybe older, maybe a little more frail, or maybe they have a heart condition that we would just want to keep an eye on. Stay in the hospital overnight, go home the next day, and then we start the recovery journey. Then they start. I like to get people into outpatient therapy as quickly as possible. Again, depending on the social situation, function, sometimes we send them into the house for the first couple of weeks until they can transition to that outpatient setting. And then as they're doing that, I make them pick a goal that they ultimately want to get to, right? That's the reason that we do all this, all the work is to get them back to doing something they like doing. So I like having that as a motivating factor or a milestone, so to speak, in their recovery journey.
I do want to mention real quick the pain protocol that you have. I do think that is something where you stand out among different providers. And I've heard you describe this before in the past, but can you describe your pain protocol and like the difference between
Yeah,
like what type of narcotics you use?
sure. That's near and dear to my heart. It's where a bunch of my research has been and is currently focused. So the old school mentality was somebody's in pain, just throw a bunch of narcotics at them. And you have many different types of pain receptors in your brain. You've got the Tylenol pain receptor, you have anti-inflammatory pain receptor, you have nerve pain receptors, you've got narcotic pain receptors. So now we use what's called a multimodal cocktail. And we call it a cocktail because all of these different medicines are like ingredients in a cocktail where they're working together to create a final product. But the 10,000-foot aerial view idea is I want to saturate all of your non-narcotic receptors around the clock and just use the narcotics in between as you see fit for breakthrough pain. So that has been a game changer in multiple ways. Number one, obviously, the narcotics have all the side effects, the nausea, the constipation, the addiction potential, things like that. But number two, it's just better pain control. Again, because all of these different pain receptors have different roles in life. And if you just use narcotics, you're just hitting one of those, and it's not even the best one to hit. So, again, that's just been a giant change in people's recovery and being able to go home and eat their own food, sleep in their own bed, as opposed to being in the hospital and then having all the complications from the narcotics build up on you, and you start to get those constipation and confusion and all that stuff. So
Yeah.
wonderful, wonderful change to the practice the last 5 to 6 years.
That first week or two is always the toughest after any replacement. And the fact that you can modulate that and get it to the point where they're not addicted to narcotics, but they're also at the point where they can move and feel more like themselves really early on is like you said, it's a game changer. So I do want to jump into more of the actual like advances in technology. I know that like robotics has been a new craze, and I do want to hear your opinion on that, as well as just kind of the different components that you can put into a hip and a knee that's changed over the years as well.
Sure. I guess let's address the robotics one first because that is certainly a hot topic. And even though everyone uses the term robotics, I really prefer the term computer assisted navigation, which is not nearly as sexy, but I think it's a little more accurate. When people think of a robot, this image comes to mind like the Tesla robot, like walking around, right? This physical being that is doing your surgery. And really what it is it's extra technology as maybe an extra check to ensure that you're balancing things or you're putting the pieces in the most ideal position that you can. So I call it computer assisted because I'm still physically doing the surgery, but there's this extra technology piece. It is really cool. Um, and as a technology nerd, it's really fun for me. The challenge for some folks is that the insurance companies often don't cover it, and so then that gets into a little situation on whether they feel like there's a big benefit or not. And I think that from a big picture perspective, that's probably worth a conversation with the surgeon about like, hey, if you got to pay for something out of pocket, what is this adding in your particular case? I think if you're a very complex patient, you've been in a car wreck and you have this crazy deformity, maybe it adds a lot for that person. For somebody else, it maybe not so much. It's a little more straightforward. But then again, everybody's a little different. There's a selection bias or remorse almost, if you will. Like if I don't do it, am I not getting as good an outcome? And I try to reassure people like that's not the case. I offer it both ways. I've done tons of them with computer assistants. I've done tons of them without. And while I think the technology is really cool, I don't, and the literature hasn't convincingly showed yet that it actually makes a tangible benefit to the patient. So if it's free and it doesn't have morbidity, we tend to use it. If it's a situation where it might be a financial hardship for somebody, that's just an honest conversation that we have. A hip is a pretty simple joint. It's a ball and socket. There's not a lot to it. The biggest things that have changed there over the years is the technology that now, at least in the United States, the vast majority of people have technology where the bone grows into the prosthesis. And that has come a long way. It continues to get better and better. The biggest other part is the plastic liner that is in there that's like people's fake cartilage. That's what used to wear out. The previous generation would wear out fairly rapidly. And that is why you'll hear people say, oh, 15, 20 years on a hip replacement. The newest stuff's been on the market for 21 years, and so far the wear rates are absolutely fantastic, orders of magnitude less than the old stuff. So we'll still have to follow it along, but so far it's incredibly good in terms of the longevity of those prostheses. On the knee side, what you're mentioning about the clicking is I call it the rocking horse evolution of the knees, where when we originally designed knees, we just designed it to rock back and forth, and there was a little post on it like you would see on a saddle on a horse. And that's what would often click with people because if that post impinges anywhere throughout your range of motion, it clicks. And people don't like that, They can feel it, sometimes they can hear it. And so the generation two of that became, well, now we have a symmetric kind of piece of plastic in there, but it doesn't have the little post anymore. So the clicking incidence went down, but we're still just a rocking horse going back and forth. And we know that the knee is not a symmetric joint. So 60% of your weight goes through the inside, 40% through the outside, and it actually rotates slightly throughout range of motion. So that's what the newer designs are trying to incorporate. And so far, the data on it is limited because they're new, but fantastic that people are saying it feels much more like a normal knee as opposed to a replaced knee.
Yeah, that's fantastic. I feel like you were so in tune with the new research. There's a lot of, I'm not going to name any providers, but they kind of stick to their old ways. And there's a lot of new technology out there that these surgeons can utilize to create better outcomes. So being up to date on your research is crucial. So one thing I want to highlight and look at is, are there any major misconceptions to like having your joint replaced? Is there one thing that you have to continue to clarify in the office about a replacement?
Um, let me do non-up first, actually, which I would say is the biggest misconception there is the whole idea of stem cells, where there's no stem cells on the US market right now that are true stem cells, meaning that a stem cell just means it's a cell that hasn't figured out what it wants to turn into in life. So we start with these stem cells, some of them turn into hair cells, skin cells, muscle, and 10, 15 years ago, people were injecting a lot of stem cells without a lot of oversight, and the FDA really cracked down on that because there were some complications. So now you can only get true stem cells in a clinical trial. There is what's called platelet-rich plasma, which is like a biologic version of cortisone injection. So you draw some blood out, you spin it down, isolate the anti-inflammatory molecules, and that's what gets injected back. But they do not turn into cartilage. They're not going to structurally change in X-ray, things like that. That's one thing that I probably see at least one person a month who's been spending thousands of dollars out of pocket on these stem cells, and they come in and they say, well, it didn't work. I still have arthritis. And so I think that's a big misconception. And unfortunately, I think sometimes it's intentional because some of the docs that are doing this want people to spend all this money out of pocket on it. I think with the joint replacement, the biggest thing that I will hear is outdated protocols. So, for instance, when you do a posterior hip and you cut the muscle, most posterior hip surgeons won't let people cross their legs or bend their legs beyond 90 degrees. When you do anterior hip, you don't cut the muscle, so there's no hip precaution. They can put their leg however they want it, but you'll have a lot of even the therapists that come out to the house sometimes, we still tell them like, don't do this, or they say, well, my neighbor told me I'm not allowed to do this. So it's just dissemination of maybe outdated information. The same thing goes with the longevity of the prostheses, where I have people who maybe waited till they're like 70 or 75, and you can tell they've really been struggling. But when you talk to them, they're like, well, I was told you don't do joint replacements on people under the age of 65. So I waited to come in, you know? And because that technology has gotten so much better, I mean, if somebody needs it, I'm pretty comfortable replacing people's knee or their hip in their, 50s and let them live the rest of their life. And is there a guarantee it won't wear out? No, but I think that where the technology has gotten now, I'm not overly concerned about it. And I'd much rather give them 30 good years to enjoy what they want to do. And if you need to do something down the line, then maybe cross that bridge when you do.
Yep. As far as recovery goes, you mentioned prehab. How important do you feel like prehab is before a replacement?
Well, it's crucial, and not just from the orthopedic side, but from the mental side as well. There is a lot of data in medicine that the more anxiety that you can remove from somebody's experience, so just a different way to say that is the more you can prepare for it. It's not only that they have a smoother experience, they actually have less pain as well afterwards. So it's trying to get them into a familiar environment. And just like people are choosing to do that as an outpatient joints, and they get to go home and they get to eat their own food and sleep in their own bed, the same thing with getting them into the outpatient therapy in a familiar environment so that they're like, hey, I met Xander a week or two or whatever before my surgery. He showed me some stuff. He kind of prepared me a little bit on what to expect for the first couple of days after and some challenges of getting around or things that not everybody thinks about. Make sure you don't have some big rug that you're going to trip on, preparing the house, things like that. So they see you and they kind of get this you know initial familiarity with you, a little bit of initial exercises, but mentally, what they also get is like they get this person that they now know that they're coming back to. So they're not worried after surgery going back into PT, like, hey, I don't know who I'm going to be working with, right? Maybe this guy's a total schmuck, and it doesn't know what he's doing. Like they've already had the chance to meet you and make that relationship. And I think mentally, just in terms of recovery, you can't say enough about that either.
Right. It's one less thing to worry about.
Yeah.
And I feel like too, what people need to understand is that when you go into surgery, you have this baseline, and that if you just are hoping that this replacement will get all of your range of motion back, get your strength back by having this new component, unfortunately, that's wrong. Your
Right.
body remembers what it could do before surgery, so the more we can build on range of motion, strength prior to that, the better your outcomes will be. And I think that's the big misconception that we see as therapists is patient comes in super discouraged because they went through this big ordeal and they were hoping that all of their problems would be solved immediately by getting these new tires, so to speak. So that's one thing that we see a lot in the clinic for sure.
Yeah, you're absolutely right. I tell them it's a team effort that, I'll do my part. They got to do their part with the therapists and working at it and same things. You're going to get out of it what you put into it. So you're absolutely right.
And finally, if someone is wanting to contact you about, getting a replacement surgery, what's the process? Do they call into the clinic?
Yeah, our clinic phone number is just 727-547-4700. And if people don't want to call and worry about, maybe being on hold for a schedule or whatever, on our website, there's also an appointment request form. So they just fill out their information and then we get somebody to reach out to them.
Fantastic. Thank you so much for being here, Dr. Dattilo. It was a pleasure having you and look forward to working with you in the future.